So we might get started. Thanks everybody for coming. Anyone would think there's an epidemic on the horizon. So it's with great pleasure to introduce Professor Raina MacIntyre. He's head of the biosecurity program here at the Kirby. Raina's been doing a huge amount of public interaction and media on this subject, and given that there was a vacancy this week, I thought there was no better person to give us an update on where we were up to with coronavirus. So, Raina, please take it away.
Thanks, Tony. Okay, so what I'm going to do is just give you a whirlwind Cook's tour of all the possible angles you might want to think about with this virus. So I won't touch on anything in too much detail because there's a lot of different things to cover. So coronaviruses are a group of viruses that are enveloped positive strand RNA viruses which infect both animals and humans. Good that they're enveloped because that means they're easy to disinfect. It's the non-enveloped viruses that are very difficult to disinfect. They have the largest genomes of RNA viruses ranging from 26 to 32 kilobases in length. And there's a range of beta and alpha coronaviruses that cause the common cold in children and adults. They can cause more severe lower respiratory tract infection at the extremes of age, so infants and elderly. And there's an alpha coronavirus that also causes pseudocroup and bronchiolitis in children. But the zoonotic coronaviruses that have jumped from animal to human and cause much more severe disease include SARS in 2002 and MERS coronavirus that is still occurring and it's been around since 2012. The new virus is called SARS-CoV-2 and the disease it causes is called COVID-19. It's very closely related to SARS. That just shows you the epidemic pattern, the comparison between SARS and MERS coronavirus, which is very different. So SARS had an R0 somewhere between 2 and 3, and it came and went in 8 months and shows a classic epidemic curve, whereas MERS coronavirus has been much more sporadic and caused occasional small epidemics over the last 8 years. This is the comparison month by month of the cases of COVID-19 and SARS in 2002, and you can see that the transmission is much more intense and widespread. It's a much steeper rise, many more cases. So the WHO was notified of an outbreak of pneumonia in Wuhan on the 31st of December 2019, and the local health authorities had picked this up earlier in December and from all reports hadn't reported on it, but the surveillance systems that they have through emergency departments to pick up severe acute respiratory illness picked up a signal coming from Wuhan, and then the CDC, China CDC went in to investigate it. So the first symptoms probably occurred around December the 8th, and the first exposure at the Huanan seafood market in Wuhan may have occurred around the 1st of December. However, the index case was not exposed at the seafood market. They didn't go to that market. So initially it looked like it was a point source outbreak. The market was closed on January the 1st, but then there was a surge in cases after January the 18th, and since then it's looked very much like a propagated epidemic. So there's Wuhan in central China, in Hubei, the Hubei province where Wuhan is. As the outbreak progressed, fewer cases had direct exposure to the market, and the surge in cases around January the 18th to the 20th coincided with the increased travel for the Chinese Lunar New Year holidays. Most cases in the rest of China still have a travel history to Hubei. China took the extraordinary measures of locking down Wuhan and other cities on January the 23rd, reducing travel out of the disease epicenter. And they further increased the New Year holiday to February the 9th, which was just last Sunday, to reduce travel, so people had to just stay where they were for that period of time. So currently there are 71,000 confirmed cases, over 1,700 healthcare worker infections, and numerous deaths in healthcare workers, over 1,700 deaths, and 794 cases outside of China, of which almost 60% are on a single cruise ship. We'll come back to that later. This shows the cumulative cases. So you can see that case numbers were pretty low early in January, and probably that's because they didn't change their case definition. They were using the clinical case definition at that stage of severe pneumonia, so not including anything that was less severe than severe pneumonia. And then you had the lockdown here, and then another change in WHO reporting. So we heard last week that China began reporting CT scan confirmed and clinically confirmed cases as confirmed cases, not just lab confirmed. And I'll discuss that later. But WHO was still reporting lab confirmed until yesterday, but today they've started reporting the CT and clinical cases as well, which is why you see this increase today. So that's new cases. So that's the epidemic curve, and this is the first case outside China in Thailand in mid-January. This is the lockdown here on the 23rd of January, and the 2-week incubation period from the lockdown is this period here, which is where you'd expect to see an impact, right, of the lockdown, and surely enough, the cases start to reduce after that. So these are the countries that are affected, both on a map and in a list there. Singapore has the largest, other than the cruise ship, Singapore has the largest number of cases, 75, followed by Japan, Hong Kong, South Korea, Thailand, Malaysia. We've got 15 cases in Australia. So almost certainly there's underreporting. We've noticed there's a low number of recovered and deaths numbers in contrast to the new cases. The first doctor to report the epidemic was initially detained and cautioned by local police. He subsequently got infected and died from the infection. There's now a lot more evidence that's accrued about asymptomatic and mildly symptomatic cases, but really we need serological surveys to really quantify it better. The early cases had, about half of them had exposure to the seafood market, but the index case didn't. They went and tested environmental samples in the market. And although it's a seafood market, there are separate sections for different kinds of food. So there's one section that's for fish and prawns, and another section that's for wild animals, another section for farmed animals. So the wild animals would be, like the bats and the animals that you might think this virus has arisen from. So they did find 33 positive samples on surfaces, but not in the wild animal section, in this fish section, which is curious because it definitely didn't come from fish. Travel to China is also a risk factor. Most cases around the world have travelled to China, but there have been two travel-related cases of people who went to Thailand and then returned to their home countries with the infection. And no one knows how they acquired the infection. Person-to-person transmission has now been reported in numerous countries. Health system transmission is also clearly a risk factor, like SARS. In one instance, there seems to have been a super spreader who infected 14 people, 14 doctors and nurses. And of course, cruise ships are also a risk factor. This is probably the best paper for estimating the disease parameters because it uses date of symptom onset to calculate the various parameters, and this is an epi curve from the very first cluster of cases, and the dark brown is those who did go to the seafood market, the light brown is those who didn't. And you can see that at the beginning, half the cases approximately had the seafood market, but those first two cases didn't. So it would be interesting to find out where they went and what their risk factors were. Case fatality rate has been controversial. Overall, it seems like it's about 2 to 3% in China. Seems to be less outside of Wuhan, but of course the numbers are smaller, particularly as you go to overseas countries. Of hospitalised cases, the case fatality in China has reported to be between 11 and 15%, and as high as 38% if you need intensive care. There is a large unpublished case series of over 1,000 cases from 552 hospitals, which says the case fatality rate is 1.36. Hiroshi Nishiura in Japan did a study based on very good data they collected and testing they did of all the evacuees from the first 3 flights from Wuhan to Japan, about 560 people, where he estimates the case fatality to be 0.3 to 0.6% based on a high number of asymptomatics. In comparison, the case fatality for SARS was 12%, MERS coronavirus 36%, the 1918 pandemic 2 to 5%, 1957 0.3 to 0.6, the 2009 pandemic 0.01. So it's in a vicinity that, you know, is certainly concerning in terms of the impacts on health systems. In terms of the demographics, initially there was an early male predominance of the cases, but very rapidly by the end of January it was equal females and males, although severe cases still tend to be more likely to be male. The median age is somewhere between 47 and 59 years, depending on the paper that you read, but the youngest cases have been reported in newborn infants. This table is from that other paper that where the epidemic curve came from, and shows you the interesting thing is the change in the gender distribution before and after the 11th of January, where it becomes approximately half-half, and the declining prevalence of exposure to the seafood market. Now this is some of the clinical characteristics and risk factors from a series of 138 patients published in JAMA. Quite a lot had comorbidities, including hypertension, cardiovascular disease, diabetes, and very few had seafood market exposure at this stage. So the other interesting thing about the clinical syndrome is that there seems to be quite a long, really mild prodrome. So that's been reported in multiple papers now. People tend to have a very mild illness for 5 to 6 days, sometimes up to 10 to 12 days before they even seek medical attention. So that's important in terms of, in Australia, in terms of our contact tracing and monitoring of high-risk people who've been evacuated or in contact or come from a cruise ship, that we need to take mild symptoms on board. And then the onset of dyspnea and more severe symptoms begins after about 5 to 6 days if it's going to progress to severe disease. Less common symptoms include headache, productive cough and diarrhea. So the cough tends to be dry. Mild cases may present with just with a common cold-like syndrome, and then others may go on to develop acute respiratory distress and pneumonia. The mean time to hospitalize from symptom onset to hospitalization was 9 to 12 days. And another report indicates 50% had chronic underlying disease, 21% have severe illness, either ARDS or pneumonia. Now, just today or yesterday, the WHO reported data from 44,000 cases in Hubei, saying that 80% had mild disease, 2% were fatal, 5% were critically ill, so requiring intensive care, and 14% had severe disease. This was the first case in the US, and I just put it up there because they collected really detailed data. And you can see here that the fever started after the cough. So the cough was the first symptom, and the fever was very, very low grade. The gastrointestinal symptoms started later. That was quite interesting. This is another paper showing the same JAMA paper I showed before, showing the frequency of symptoms again, that fever is pretty ubiquitous. The other symptoms get less and less frequent. And they also showed this long duration to hospital admission, to shortness of breath, and to ARDS. This is the laboratory findings. Essentially, you might see a neutrophilia and a lymphopenia and a raised prothrombin time. This study shows the complications, and shock, acute cardiac injury, interestingly, is almost as common as, and arrhythmias together is as common as ARDS. And acute kidney injury as well was seen in 3.6%. This is the chest CT scan from a patient who was in intensive care. This is at day 5 of the illness, day 5 after hospitalization. You can see the ground glass appearance. The lungs are kind of whited out with that pneumonia. And this is on day 19 after he's had ECMO, which is extracorporeal membrane oxygenation, where they just take the blood out of your body, oxygenate it, and put it back in. Reinfection, this is an interesting question because there's been some news reports saying that some people have been reinfected and had a much more severe clinical illness. Certainly reinfection has been documented with the seasonal coronaviruses in the day when you could do challenge studies. There's a study in the 1990s where they did that. But they didn't tend to get clinical illness. They were shedding virus, but they didn't tend to get clinical illness. There's been quite a few studies of SARS, which show that IgG is undetectable in 11% of patients after 16 months, but the neutralizing antibodies decrease markedly after 16 months, and they're the ones that are protective. And there's a substantial reduction of antibodies after 3 years. So maybe after 3 years, you're not so protected. There is, however, a memory T cell response that persists to at least 6 years post-infection. In a ferret model of acute infection with SARS, the response was dominated by interferon response gene expression, IRG, but it was, when they reinfected the ferrets, it was absent. So we think that the SARS virus can suppress the induction of interferons. Whether it happens with this virus, we don't know, but there's a lot of immunological research that still needs to be done. The treatment essentially is supportive, which includes intensive care, oxygen, ventilation, ECMO. Broad spectrum antivirals are being used, but they're unproven. Lopinavir and ritonavir were used during the SARS epidemic and are being used currently in China. They bind to the same target site as a 306 amino acid long main protease, MPRO, which is a key enzyme for coronavirus replication. But there's no evidence from a systematic review of SARS treatment that they are effective. Animal studies suggest that remdesivir and interferon beta are more effective than lopinavir and ritonavir. This is a nucleotide analogue developed for Ebola and Marburg virus. There are currently clinical trials of both remdesivir and combination lopinavir and ritonavir going on in China. Other drugs that are being used, for which there is some evidence in laboratory and in vitro studies, include chloroquine, ribavirin, and a few others. There's no evidence for effectiveness of steroids, but selection bias is highly likely that the more severely ill patients get treated with steroids, and so they're also more likely to die. There's reports that plasma from recovered patients are being used in Shanghai. So this shows the effect of remdesivir and chloroquine in inhibiting COVID, the coronavirus, SARS coronavirus 2. And you can see this is the remdesivir, and that's the chloroquine. The pink is the inhibition, and the bottom blue line is the toxicity, the cytotoxicity. So remdesivir really looks quite good compared to the other drugs. This is the comparison of remdesivir with combination lopinavir and ritonavir and interferon beta. And you can see again that the inhibition of the virus is in the top line with the dark balls, and the blacks, the squares, sorry, is the cytotoxicity. So the remdesivir really looks quite good compared to lopinavir and ritonavir, and even the combination of both. And the interferon beta looks quite good as well. In terms of diagnostics at the moment, the main diagnostic is PCR, but the site of sampling really matters. There's now been a number of studies that have shown that multiple throat swabs can be negative in someone with confirmed infection. And if they are at risk, if they've come from a high-risk place, or if they've been a known contact, you need to keep testing, particularly if you're using the throat swab. A sputum is more likely to be positive than a throat swab. The viral load is higher in the lung than it is in the throat and the nose. So there's been quite a bit of talk about the use of CT scan for diagnostics and chest X-ray, and I think it's a pragmatic decision that's occurred in the epicenter of the disease because sometimes the PCR is negative, and there's a nice study here by Z et al, which shows that in 5 patients who had repeated negative PCRs, the chest X-ray was positive and showed the typical ground glass opacity. And I think if you're in an outbreak setting where there's a lot of disease and the positive predictive value of the chest X-ray or the CT scan is going to be high, and from an infection control perspective, it is quite sensible to use that as a diagnostic and isolate the patient, treat them as if they were a case until you can get some sputum. In terms of vaccines, there's actually been quite a lot of work done on SARS and MERS vaccines already, and there are groups, including the University of Queensland, working on, and the Doherty Institute, I believe, working on vaccines. There's a whole range of different approaches that have been used. The inactivated vaccines require really high concentration of virus and is thought to be quite, there's issues around safety for laboratory staff working with it, and there's also worries about the inactivation not being complete. You may recall there was a famous incident with the polio, the inactivated polio vaccine, which was accidentally still contained live polio in the 1950s. Lots of kids are vaccinated and they got paralytic polio. So that's the concern with that one. The live attenuated vaccines also, there is a concern because the virus is excreted in the feces, and with any virus that's excreted in the feces, like polio, it will end up in your waterways, and it could revert to pathogenicity in the environment. So that's another concern. The protein-based viruses basically are, trying to replicate the spike protein, which is the most immunogenic part of the virus, and they also have some safety concerns. The inactivated ones also in some coronaviruses, there's a feline coronavirus, causes probably an immune complex mediated phenomenon where they get quite severely ill after vaccination, the cats anyway. It hasn't translated into mice and other animals, but there is a concern about triggering some kind of immune syndrome from those vaccines. So I think the most promising vaccine approaches are the vectored vaccines, so on something like modified Vaccinia ankara or adenoviruses, VSV, DNA vaccines as well, and combinations of the different approaches. Realistically, it may take 12 to 18 months before having a vaccine, and I think it could be sooner because there's been a lot of work done for MERS and SARS vaccines. And there has also been work since the Ebola epidemic to actually accelerate the development of vaccines to bring them, normally it takes years and years because you've got to do the safety trials and, all of that stuff. So there are now processes through organisations like CEPI that can get these vaccines to populations more rapidly. I think the issue of reinfection is important, and the immunity, how long will these vaccines be immunogenic is another thing that needs to be studied, and whether there's any adverse effects of revaccination. In terms of the phylogenetics, the virus is about 88% similar to bat-derived coronaviruses, beta coronaviruses, and it's 79% similar to SARS and about 50% similar to MERS coronavirus. I would recommend nextstrain.org, which is a really good site for looking at emerging infectious disease phylogenetics. See if we can get it up, the tree. No. Okay. No, I can't see it. Okay, we'll just move on. So the incubation period has also been controversial. We're told it's 1 to 14 days. The mean is not a useful value. Really, you need to know the median. But a lot of the papers have only published a mean. So the mean is 5.2 days. That unpublished case series I mentioned says that the median is 3 days, and the range is up to 24 days, which could explain the lady who got infected on the Westerdam ship, because people were looking at the 14-day incubation and said, how could she have got infected? The R0, I would go with that Lee paper in New England Journal because they use date of symptom onset as the best estimate, is 2.2, but some of the estimates have been as high as 7. The serial interval, again, from that Lee paper is 7.4 days. That from the same paper, these are the ranges, the distribution of these parameters. Days from infection can be, almost 0 to 21 days. Serial interval, again, a large range. Interestingly, they found a difference in the cases before January the 1st and between January 1st to the 11th. but a similar kind of range. Pre-symptomatic and asymptomatic transmission is also has been controversial. It's an emerging picture. We're getting more and more information every day. It was reported from China back in the middle of January. There was then a German study that was discredited because the patient actually had symptoms. But the Japanese did a really nice study. They actually tested everyone among their first batch of evacuees. So they had about 565 people come on 3 flights evacuated from Wuhan. They were the first evacuees out of Wuhan to any country. They tested everybody, whether or not they had symptoms, and they found 8 people were positive, and of those, 5 had no symptoms. There's also a case series of children, and they found that these were all infants under the age of 12 months. One of the 9 infants in that case series in an infected family was tested positive but was asymptomatic. On the Diamond Princess, the cruise ship that we're hearing about, we've just heard that they tested everyone on the cruise ship, right? Because they made a decision not to take the sick people off to treat them in Japan. 70% of everyone who was testing positive was asymptomatic on that cruise ship. There was the case on the Westerdam cruise ship, which was the one sailing around the Pacific and no one was allowing it to dock. It docked in Cambodia. This lady who got off there, within a day they docked again in Malaysia, and she presented with symptoms and is a confirmed case. It's a mystery where she got infected because there was no outbreak, no clinical outbreak on the ship. This was also one of the early cases reported in the Lancet, which was a family that had a cluster of infection within the family. This CT scan is from a 10-year-old child who had no symptoms but was tested with a CT scan anyway, and he had pneumonia. So, which raises the question of whether children are able to transmit asymptomatically. Are they the silent reservoir that are not being detected? So transmission is probably by contact, droplet and airborne, just as it was for SARS. It is a respiratory virus. There is documented to be a higher viral load in the lower respiratory tract than the upper, which is consistent with airborne transmission. It was found on the surfaces in the seafood market. So contact infection could be self-contamination, so you touch an infected surface, you rub your face, you stick your fingers in your mouth, whatever. And also ocular transmission probable ocular transmission has been documented in one study in a person who a healthcare worker who wore PPE, respiratory protection, but didn't wear the goggles and developed infection and red eyes. So because it's an envelope virus, it is inactivated by standard disinfectants. There's no evidence of vertical transmission, but there is evidence of transmission probably during birth, because there's been a couple of cases now reported where the infant was infected within 30 days of the mother giving birth. But the placenta, the breast milk is all negative. So for contact transmission, hand hygiene is really effective. There's been numerous randomized controlled clinical trials of hand washing. Soap and water is as good as alcohol hand gels, and it works against a range of different pathogens, viral and bacterial. Disinfection and decontamination of surfaces is likely to be effective. Surgical masks, because it stops you putting your fingers in your nose or your mouth. We touch our faces 200 times a day on average. Gloves, gowns for healthcare workers, and other hospital infection control measures, including spatial separation of contaminated zones and uncontaminated zones, and cohorting of patients. I'll just talk briefly about droplet versus airborne transmission. It's basically a paradigm that drives hospital infection control and has done for more than 60 years, and it's the belief that large droplets will be emitted close to the patient and smaller droplet nuclei become airborne and persist in the air at a greater distance for longer periods of time. It's based on experiments from the 1940s and 50s using very blunt cameras. Newer research shows that both small and large droplets can both be present close to the patient and further from the patient. And we know from numerous studies of infectious diseases that healthcare workers are at much higher risk of a range of different infections. So droplet transmission theoretically favours infections where the highest viral load is in the upper respiratory tract. whereas airborne transmission favours infections with the highest load in the lower respiratory tract. We know from influenza studies that you can get influenza virus expelled in the air through just tidal breathing. You don't need to cough. And we know with this virus that there are higher viral loads in the lower respiratory tract, in the lung. So it makes sense that there would be airborne transmission. You may remember the Amoy Gardens outbreak in Hong Kong of SARS, which was where it was spread from floor to floor and building to building through aerosolization of fecal material in the plumbing. So it's been reported with COVID-19 that there's a building in Hong Kong where people have been infected floor to floor without any other obvious contact. I haven't seen anything more about that, but that will be an interesting one to watch. One of a UNSW PhD student that I co-supervise, who's in engineering, Pradeep Bal, has done some really nice research, and he's put together all the evidence of the horizontal distance travelled by large respiratory droplets, and this is in feet, so it's 3 to 6 feet, is 1 to 2 metres, which is what we say is a distance of spatial separation, and most studies show that it can travel further than that, okay, much further. And Pratik is also doing some really nice research on sneezes and coughs, and another thing which there's not much in the literature about is how different sneezes and coughs are. This is a sneeze, and he's measuring the velocity and the distance in this research, and he's done some, his primary supervisor is Professor Condulan with Dr. Charitha De Silva, and I'm a co-supervisor along with Abrat Chuptai in the School of Public Health. So, you know, what he's found is that there's huge variation between people and even within people. So if you record different sneezes or coughs in one person, you'll get completely different results. And a lot of the literature really is on a single cough in a single person or a single sneeze in a single person. Oops. So pathogens generally do have a predominant mode of transmission, but transmission is rarely just through one mode. Experimental data done in a controlled setting doesn't account for the complexities in a clinical setting or inter-host variations. Influenza is predominantly droplet, but now there's numerous studies that show that it's airborne, including a study that shows that 3 hours after a patient with flu has been in the emergency department, you can isolate viable virus in the air. SARS was also shown to be both airborne and droplet. So surgical masks are designed to protect surgical wounds against infection. RCTs done against this indication do not show efficacy. They're not regulated on filtration or fit. They're not regulated at all. They tend to let a lot of air in through the sides, but they probably do provide some protection against touching your face. Respirators, on the other hand, are designed as respiratory protection. They're designed to fit and to seal around the face so there's no leakage of air, and they're regulated on how much they filter the particles. So they have to filter more than 95% of airborne particles, which are particles that are 5 microns or less. So there's only been a few RCTs, including some that we've done. They generally, the only positive finding has been that N95s are protective, which was in the trials that we did. And this trial down here, which was published last year, the Radonovich trial, it was a large trial, the largest to date. The intervention they looked at was targeted use of the respirator. So the healthcare worker had to wear it when they were doing a high-risk procedure, such as intubation or giving salbutamol or by nebulizer, those kind of procedures. The rest of the time they didn't wear it. And in our trials, we compared that strategy with continuous use, and only continuous use was protective. And I think it's because healthcare workers don't always know when they're being exposed to something in a hospital, which is a very contaminated environment. This was our first trial, control in blue, surgical in red, N95s in green, different outcomes there from clinical respiratory illness to ILI to any virus being isolated on a multiplex PCR to influenza. And you can see that it looks like there is some effect of the surgical mask. It just wasn't statistically significant. The only significant protection we found was with the N95s. And this is the trial where we looked at targeted versus continual respirator use. Just to say there was no difference between a targeted N95 and a surgical mask, no significant protection. The only significant protection was if you wore the respirator in the whole shift. And this is a study that we did where we looked at, we pulled the data from 2 of the trials and looked at all the different outcomes, and then we separated the infections into ones which are believed to be droplet spread and ones which are believed to be airborne spread and other spreads. And even against infections that we say are droplet spread, a respirator protects you significantly, even a targeted respirator, but not a mask. I mean, you know, the mask probably gives you some protection. You can see from the box plot, the forest plot here, but it wasn't significant. So when we compared against control, it was significantly protective against influenza as well. So in summary, there's mixed results from observational and in vivo studies. The observational studies from SARS favoured both the use of face masks and respirators, or both, in healthcare workers. The RCTs generally show the degree of protection increasing from cloth to medical to respirators, but there's no evidence of efficacy for masks in health workers. So let's move on to the epidemic modelling and predictions. We've seen a range of different predictions from different expert groups. In terms of the R0, I think I'll go with the Lee estimate of 2.2 because they use the best data. Most of the other estimates of R0 have used date of reporting of the cases, which is, you know, what you know about when especially somewhere like Wuhan, where they're really under the pump with managing the acute situation, you can get lags and surges in reporting, so the reporting date may not reflect the onset date. We also do need serosurveys because a similar, it was predicted with MERS coronavirus as well that there was massive amounts of asymptomatic transmission, but the serosurveys didn't actually support that. They found very low levels of seropositivity, even in camel handlers. We've seen various predictions of the peak in February and April. This is the difference that date of onset versus date of reporting makes in the epidemic curve. And these curves are reported by the WHO. They provide an epidemic curve for the overseas cases outside of China. This one is by date of symptom onset. This one is by date of reporting. And you can see how different they are, right? So if you use these data, you're going to get a very different estimate of R0 than if you use these data, which is why it's really important to use data that have the date of symptom onset. These are the modelling predictions from a study published in the Lancet, which suggested the epidemic would peak in April. Again, they use date of reporting, so there's some uncertainty in these predictions. This is a really nice study from the London School. It's in an unpublished repository, and this one predicts the peak in February. This is also a really nice study from authors at Harvard, which looked at the travel patterns from different countries to China and from China, and then looked at the observed number of cases in different countries and what they predicted from their model. So this is what their model predicted. These were the ranges, the dotted lines. So you can see that Thailand has less than what they predicted. Singapore has more than what they predicted, and Indonesia as well has less than what they predicted, which is why you've read a bit about Indonesia in the media. This model predicted that we should be seeing cases in Indonesia, but there's been none reported today. Just going back to that study by Nishiyura, they looked at the 565 citizens evacuated from Wuhan between January 29th to 31st. At that time, there were 1,900 confirmed cases in Wuhan. As I said, they screened and tested every passenger. They found 8 positive, 5 asymptomatic, and from that, they estimated that the case ascertainment rate was 9.2%, which means like 81% of cases are not being diagnosed. And the reasons would range from asymptomatic or mild illness to underdiagnosis or underreporting, and probably a combination. So there's also been a lot of discussion about, should we just let it come? It's going to be a pandemic. Why don't we just let it come? Why are we persisting with these measures like quarantine and lockdown? It's, you know, why don't we just let it come? It's going to come anyway. What we're doing at the moment is holding the line, which used to be called Stamp It Out. It's still called Stamp It Out in New Zealand in their pandemic plan. which is where you aim to prevent sustained community transmission, defined as more than 3 generations of transmission. And the methods include vaccines, drugs, quarantine, travel restrictions, border control, case isolation, contact tracing and surveillance. These are all proven public health measures to reduce the transmission of epidemic diseases. The effectiveness really depends on the latent and infectious period. So in some instances, you don't have to quarantine people. You can just monitor them for symptoms. They can go about their business. You just contact them every day, check if they've got symptoms. So that's symptom monitoring without quarantine. If, however, the disease has asymptomatic or pre-symptomatic transmission, you need quarantine. Okay, symptom monitoring isn't going to work. This is from an older version of the US pandemic plan, which just illustrates really nicely the principle of holding the line, trying to stamp it out. Even if you can't prevent it coming, what you will do is delay the peak and reduce the total number of cases. And that's the disease control objective, because in doing that, you're buying time, during which time you're closer to a vaccine being available. So you're going to have less morbidity and mortality in your population if you can just delay it. You may not be able to stop it coming, but you must try to delay it to reduce the overall morbidity and mortality impacts. This is also a really nice paper that illustrates the differences between different infections. This was published a couple of years ago from Harvard. And it shows a range of different infections, pertussis at the top and smallpox, so basically the diamond, if you can see it, is the R0, okay? And then you've got the effective R with either quarantine, which is the circle, or symptom monitoring, which is the triangle. So in a disease that has a huge asymptomatic transmission component like hepatitis A or influenza, you see a big difference between quarantine and symptom monitoring, right? But in a disease where there's very little pre-symptomatic transmission like SARS, there's not a lot of difference. So if the disease doesn't have pre-symptomatic or asymptomatic transmission, you can get away with symptom monitoring. But if there is, then you really need to use quarantine. That's what this illustrates. So we've done some research on case isolation as a strategy. It's known from the pre-eradication era of smallpox, which is also a respiratory transmissible virus, that case isolation reduced transmission to just about 0. And this just looks at if you've isolated 30% of cases in blue versus 50% versus 90% in grey by the day of starting your response. Remember, these are epidemic diseases, which means every day counts. Every day of delay will result in a much bigger epidemic. And it's best if you start as early as possible. Isolating more people will give you a smaller epidemic. This is a similar study looking at the impact of case isolation in Ebola, done by Martin Meltzer at CDC, where they showed very nicely that during the 2014 epidemic, if you've got 70% of people into Ebola treatment units in isolation, you could control the epidemic without any drugs or vaccines. And that actually became a disease control goal after this paper was published. So if we just kind of let it come and don't get too fussed about trying everything to stop it, then, this is again smallpox, this paper that we've published. But if you only isolate 50% of your cases and contact trace and intervene with 50% of contacts, then you could end up with an epidemic that goes on for 8 years plus, so it becomes endemic. Whereas you can control it within a year if you throw everything at it in terms of just case isolation, contact tracing. So we also looked at health systems impacts, which is, your healthcare workers and their needs, public health, which includes contact tracing, vaccination campaigns, etc., capacity for isolation, intensive care. And we've got about 100,000 clinical health workers in Sydney. We've got about 14,000 public hospital beds and about just under 6,000 private hospital beds. We estimated there's about 330 public health workers in Sydney who can do surveillance, contact tracing and monitoring. And what we found with this modelling study that was published a couple of years ago is that you'll very quickly exhaust your capacity for isolation beds and intensive care. Stockpiles won't last that long if an epidemic's going on for 6 to 12 months. Any epidemic that's ongoing for about 6 months will require about 30 million masks and respirators. A cruise ship is a particular challenge for disease control. Up until now, in Japan, for instance, the people who were getting sick on the cruise ship, the Diamond Princess, were being taken on shore and treated in the hospitals there. But if you've got hundreds of cases in a cruise ship on your shore, that could end up really overwhelming your health system and causing more transmission, nosocomial transmission. So it's a really difficult issue. So let's talk a bit about the cruise ships before finishing up. Cruise ships are documented to have had multiple outbreaks of influenza, norovirus, and other epidemic infections. So the largest outbreak outside of China, 454 cases, is on the cruise ship, the Diamond Princess. The Japanese authorities are now testing everyone on board, and they say that 70% of all positives are asymptomatic. In fact, asymptomatic infections may explain the Westerdam case, the lady who got sick without any known contact with anyone, without any outbreak being apparent on the ship. So contact spread infections are especially challenging for decontamination of surfaces on something like a ship. Passengers tend to be short-term. They tend to be on the ship for 2 weeks or less, but the crew are longer term. So if there's ongoing epidemics, often it might be a crew member who's a reservoir who's infecting new passengers as they come in. They tend to be quite long term on board the ship. So, and during serious epidemics, we've seen with this one that there is a high risk of cruise ships being denied entry at ports like the Westerdam, it's also such an intense setting for transmission. Several countries have blocked cruise ships from docking, including Malaysia, which has said it's not allowing any more ships to dock. And of course, evacuations are more complex from a ship than from land because you've sort of got a two-stage process instead of one stage, which carries with it more risk of infection and transmission. So have the lockdowns and travel restrictions worked? Well, I think it's worth just stopping to consider that what they did in China is unprecedented. It's never happened in history. The lockdown in Sierra Leone and Ebola was tiny in comparison. Over 500 million people in China have been under lockdown or travel restrictions. That's more than the entire US population. Half of China, over 780 million people, have been under some sort of travel restrictions. And other countries have implemented travel bans and quarantine. So you've seen the interventions at both ends to stop the transmission. But I think it's worked, but it's a huge price that people in China have paid for our benefit, for everybody's benefit, for the benefit of people in the other parts of China and for the benefit of people in other countries. They've paid an enormous price. So what I did here was I broke down the cases in Hubei province versus the rest of China. So the lockdown was here on January the 23rd. That's the incubation period, 2 weeks, which is when you'd expect to see the impact, right? After the incubation period, after all the cases that are going to occur have occurred. And we do see this decline, particularly in the rest of China. So I think this shows an impact to the rest of China, and obviously the epidemic curve is now on the way down. That's just cases in Beijing and Shanghai, which show the same phenomenon. This is the cases occurring outside of China from the WHO, and there's the incubation period after the lockdown. And again, we see that effect, right? So what's going to happen? There could be, the holiday season ended on the 9th of February, and the 21st of February is a 2-week period after that. So we may see a surge of cases after that because people started moving around again after the 9th. There are obviously massive economic consequences of travel and trade and lockdown, etc. Essential medications. So many essential medications are made in China. Most PPE is made in China, and they're struggling to meet their own needs, which means everyone else is going to have even more of a shortage. I read an article that showed that the US gets all its heparin from China. So they have an immediate problem of supplies of heparin to their hospitals. It will take them, a few years to build domestic capacity to produce heparin. I think they get a lot of their insulin from China as well. So there's a lot of flow-on effects that eventually countries will have to make a decision about lifting the travel bans and decide that balance between the economic consequences and the public health consequences. And I think cruise ship management is a really difficult question, particularly if you've got a ship on your shores with large numbers of cases and you don't have large numbers of cases in the country. So that's it, a little bit of time for questions.
Questions for Raina? Raina, I was intrigued by the disconnect between the fact that the Japanese found all that asymptomatic disease. Presumably the swabs were throat. They probably haven't gone to the trouble of inducing sputums and those sorts of things. So, but the viral loads are higher in the lungs. So, I mean, I know there's a lot of variation in these in-house tests that are being used for these PCRs, but what do you think is driving that? Just the Japanese are more precise? Or?
I actually think it's now that they've done that, I think every other country is going to have to think about whether they test everybody that's coming back from either from an affected area or from a cruise ship who's going into quarantine, because you don't want infection being passed around in quarantine centres either.
It'd be really nice to know how they collected those samples.
That were throat swabs.
That were throat swabs. Yeah. And just a standard
PCR, yeah.
And my question is, looking into the available data as of today, sort of epidemic and clinical patterns, coronavirus is not, the novel coronavirus is not very different from the seasonal influenza outbreak that we see every year in terms of infectiousness or mortality as per documented. What do you think, apart from the fact that it's a novel virus, what do you think are the key factors driving the huge panic and hue and cry and all this sort of media heightened attention for this particular outbreak?
So the question was, it doesn't seem to be very different from seasonal flu. What's the panic about? Actually, if you go back to the case fatality rates that I put up there, it's actually much more serious than the 2009 pandemic. It's about similar to maybe the 1957 pandemic. So we're talking about an infection that's going to cause, leave aside the people who will die, there's going to be an enormous surge requirement in hospitals and the health system to treat severely ill people. You will run out of ICU beds. You may not be able to ventilate everyone who needs to be ventilated. Remember that we have an ageing population in Australia, right? This disease affects older people more severely. We also have more immunosuppression because people have more medical immunosuppression in a country like Australia. So, yeah. John.
Yeah, I think that's a very important point. I don't know if you saw that the China CDC produced a report of 72,000 cases the last couple of days, which was the first time since everybody broken down the case fatality rates by age. And they're still pretty impressive. So it's not just the elderly. I know the definition of the elderly these days. I'm trying to ignore that. But even within the age of 50 to 59, the case fatality rate was quite substantial, 2 or 3%. And people, you say that to people in the street, and they say like 2 or 3%, but that 2 or 3% of the Australian population is actually hundreds of thousands of people. So it is very encouraging that things do seem to be dropping off in China. But the other point I make is that you made the point about, is it worth trying to hold off for as long as possible? And I think the idea that the vaccine is coming is nice to think about, but realistically we know we've had people with HIV had that going for a few decades. It should be faster here, but certainly not a given. But what I think is really important is that preparedness side here, and whether it's planning for ICU beds, or whether it's making sure everyone's got a test ready, or whether provision of other forms of facility. We are astonishingly underprepared here, even after years and years of pandemic planning and all sorts of exercises and wargaming. The Chief Health Officer meeting every day for an hour and a half, the CNA is meeting every day for an hour, and rightfully so, because so this is serious. This is serious.
So John Caldor was just reiterating the case fatality rates, particularly in the older age groups, for those of you who didn't hear, who are not here with us physically. and made some good points about the data he's seen about the mortality rate, case fatality rates in older people, that it will substantially test our health systems. I think the other point in terms of quarantine and border control and measures to stop it or delay it is that we're an island, and that does give us a slight advantage in that we don't have land borders like many other countries do to deal with. We've only got the sea and the air to worry about, which makes it a little bit easier. Obviously, it's not 1918, not like 1918, but in 1918, Australia managed to hold off the pandemic, delay it for a year, full year, compared to the rest of the world through all those kind of measures. So there is, we have a slight advantage in trying to delay it.
Andrew.
Thanks, Brandon, for a great presentation. One question you didn't say much about is the likelihood of spread to a country. Isn't screening people coming from China to African countries? There's a lot of movement of Chinese workers from Africa, or Indonesia or other countries. How possible or likely do we think that is? And is anybody approaching monitoring for it?
Yeah, so the question from Andrew Grulich was about people coming in with the infection from other countries where there might be a lot of movement between China and other countries such as the African continent. At the moment, not many countries are screening and monitoring, but I think as soon as there's evidence of sustained transmission, and we need to be doing active surveillance, I think, to look for evidence of sustained transmission around everywhere, really. And if there is, then we need to rethink our policies.
Done with that.
I guess given that it's like in China, like there's people that break down, and at the moment, it's also how worried should we be in metropolitan Sydney, catching trains and things? And I guess, you do people have masks and things around the place. Is it something that you think we should actually be aware or scared or worried about or just aware of?
So the question was, how worried should we be in metropolitan Sydney? At this stage, there's no evidence of sustained community transmission in Sydney or anywhere else in Australia, so I don't think we need to be, panic buying masks or stockpiling on various things. But if there is evidence of sustained community transmission, then, we move to a different phase of mitigation in our planning.
Yes, thank you so much. So we noticed that Hong Kong has the cases about 9, but they were excluded from the travel ban such that the citizens of Hong Kong still travel to Australia and many other countries. And I just wanted to ask you, why is that? And within Hong Kong, how effective have things been actually limit intermingling from the mainland? Because I read news that was giving counter-raising reports, and then of course what impact does this have for the geopolitical tension? Because Hong Kong, one person commented it's being put up as Singapore, US, Hong Kong, primarily is part of the People's Republic. So what impact does that also geopolitically how it's recognized?
So the question was about Hong Kong, that there's no travel restriction for people in Hong Kong, how much movement is there between the People's Republic and Hong Kong SAR. And I understand they did stop the flights. I don't know how much movement there is between Hong Kong and China, but obviously that's a concern. I mean, it's a concern anywhere in terms of how many people are crossing borders in ways that we're not monitoring and have the potential to spread the infection.
And one last question.
If it does get into darkest Africa, is there any chance of stopping it? Spreading all to Africa?
The question was, if it does get into Africa, is there any chance of stopping it? Yes, I think so. There's very good public health infrastructure there, particularly in countries like Nigeria, which have had a lot of experience with polio. They actually did an amazing job during Ebola, stopping a massive outbreak that could have taken off in Nigeria. And I think they drew on their experience with polio and the infrastructure they had with polio. So yeah, I would hope that they do. Plus, with the international health regulations and the WHO works closely with all countries in these situations.
Okay. Raina, thank you very much for a great lecture. Thank you.